Hello and welcome to the World Stroke Day. Today we'll be talking about multiple aspects of stroke, from definitions to risk factors and how common stroke is, and then how we identify strokes and treat them. I'll be talking first about the stroke prevention and risk factors. I'm Moyed Al Khalifa. I'm a vascular neurologist. Stroke is a sudden and serious medical condition that happens when blood supply to part of the brain is interrupted, either because of a blockage in a blood vessel leading to loss of blood and oxygen supply to that part of the brain, or hemorrhage, bleeding in the tissue of the brain due to rupture of one of the blood vessels, and both lead to loss of function of that part of the brain. 1 in 4 people in their lifetime will have a stroke, and stroke is the leading cause of disability in the world, and it is the second leading cause of death globally. It is estimated that stroke affects 13 to 20 million people in the world annually, and in Saudi Arabia, currently the estimated number of strokes per year is 18,000, and it is estimated to increase to 22,000 by the year 2030. Stroke risk factors are mostly preventable. Strokes are, or actually 8 of 10 strokes are preventable, and it is mostly related to those modifiable risk factors, including high blood pressure, high blood sugar or diabetes mellitus, high cholesterol levels, physical inactivity, obesity, or smoking. Other risk factors are not modifiable, and they are a lot less than the modifiable risk factors. Those include age, gender, and family history. So focus on your modifiable risk factors, consult with your family practitioner, and find out if you have one of those risk factors and treat them effectively as early as possible to prevent a stroke. Thank you.
Hello, everybody. We will be talking about continuing to speak about the stroke, and I'm going to emphasize on the stroke burden and the stroke prevention and medical management of a stroke. So my name is Dr. Shireen Qureshi, and I'm one of the consultant neurologists at Johns Hopkins Aramco Healthcare, and also I'm an adjunct faculty member at Johns Hopkins Medical. Well, we know over the years the stroke has been on the rise, and and our kingdom is no different than the rest of the world. Usually, stroke is more prevalent in male as opposed to female. Although after menopause, this gender difference starts to narrow. The gap starts to narrow. Usually, stroke is two major types. As you've heard in the previous presentation, stroke is either ischemic one, which is the majority of the strokes, and the second type is the hemorrhagic one. So the ischemic stroke, where there's a lack of blood supply to any area of the brain, is caused by a blockage of a blood vessel. And usually there would be a clot, and that would lead to a clogged artery, either with fatty deposition or just the clot itself. Cause second is because of the atherosclerotic disease. Second type is the hemorrhagic, which are less common, about 15 to 20% of all the strokes. These are caused because of the rupture of any of the blood vessels in the brain. The vascular risk factors that cause the stroke per se, number 1 and 2 and 3 causes are hypertension. So take care of your blood pressure as you are aging, because it is one of the major risk factors. Diabetes, obesity, and obesity-associated metabolic syndrome, coronary artery disease, and smoking has been considered as independent risk factors that cause a stroke. Now, there are the risk factors. Those we can modify, but there are certain things we cannot do much about, I mean, as we are aging, we cannot do much about that. So as you are getting older, you are having more and more likely to develop stroke. Male gender, as I mentioned, but women can have strokes at younger age due to some hormonal issues, contraception, or sometimes pregnancy-related different types of stroke. Family history is an independent risk factor, and certain races, like the African Americans, are at high risk of developing more of an hemorrhagic strokes. So we have to concentrate on the modifiable risk factors. We have to do a lot about it, and that is extremely important so that we prevent the stroke from recurring. We all know that a penny spent in prevention is a lot better and more effective than a dollar spent in treatment. Um, these are just the overview of all the risk factors, and as I said, these have been there is usually a way for us to calculate the added risk for different patients. Now, if somebody gets one other way of preventing is medically is to start the patients who develop strokes or have certain risk factors based on the advice of your physician is to start taking aspirin. Now, aspirin is an antiplatelet medication which prevents the blood clots from clogging and closing or blocking the blood vessels, and it is a very effective treatment. Some other antiplatelets are also effective, such as clopidogrel, and sometimes we need to put patients on some anticoagulation. So these are just preventative. One of the preventative measures, they are not the main thing. Your lifestyle and modifiable risk factor is the main thing. So overall, a stroke remains a major health burden. It is preventable, treatable, and beatable. We need to act on the stroke very urgently so that we can save lives and improve the community outcome secondary to stroke. Um, I will just go over also what for you to understand what a stroke is. Be aware of the major clinical presentations. So if you see somebody who has developed some symptoms like sudden onset of headache, sudden difficulty in speaking, slurring of speech, sudden loss of vision or double vision, or sudden weakness in the arms or legs, these are urgent signs that may warrant that the patient may be having a stroke or associated with some problems with balance. Take those patients immediately to the emergency department because we can save them and improve their stroke outcome very effectively if they come in a timely fashion. Time is brain. Every minute counts for a brain cell that we can salvage if treated early. And usually, if they come within 4.5 hours, we can give them some clot buster medications through their veins. And sometimes, after a longer duration, if they had certain major blood vessel occlusion, we can do a catheterization like treatment and dislodge those clots so that there will be again the perfusion of the blood in that part of the brain that can have less ischemia, and we can salvage the brain. So in summary, again, the stroke, we have to identify the risk factors for prevention. We have to identify the clinical presentation so that we can help somebody and then manage them with medical management and with certain specific medications. Thank you very much.
Six, 7, 8, 9, 10. Bismillah ar-Rahman ar-Rahim. My name is Yusuf Al-Bustanji. I'm a speech language pathologist consultant, and I'm happy to be with you today and talk about stroke-related language and swallowing disorders. This events come on World Stroke Day. So the main purpose behind this presentation, along with my colleagues, is to increase the professional knowledge about the stroke and its impact on various functions of the human body, like language, swallowing, motor abilities, and other functions. I'm joined with Dr. Shireen Al-Qurashi and Dr. Muayyad Khalifa from our colleagues from neurology, and Mr. Fawaz and Mr. Abdullah from the rehabilitation department. I'm a speech language pathology consultant, and I'm working with stroke victims who have speech and language problems as well as swallowing disorders. So the main purpose behind this presentation is to increase the knowledge about stroke and its related language disorders like aphasia and its related swallowing disorders like dysphagia. We will talk about risk factors, signs and symptoms of aphasia and dysphagia, protocols for treatment, assessment and rehabilitation options that we have here at Johns Hopkins. Before that, we all know that stroke is an emergency medical condition, and it has tremendous impact on the human functions, as I said, like swallowing, speech, motor abilities, even emotional and all aspects actually of quality of life. Stroke mainly two types, as Dr. Shireen maybe elaborated on this, ischemic stroke and hemorrhagic stroke. The reason why I'm bringing this slide is to not only to describe the difference between them, because Dr. Shireen already covered that, but ischemic stroke is more common than hemorrhagic stroke. It's about 80%, while hemorrhagic stroke is about 20%. With respect to speech and language abilities, we are interested in this kind of differentiation because of the prognosis. We expect the prognosis to be faster with victims of the hemorrhagic stroke compared with the ischemic stroke. Ischemic stroke caused by a blood clot or blood cut that prevents the blood from reaching vital brain areas, while if there is a hemorrhage or a brain burst that causes bleeding around certain brain areas, it may cause hemorrhagic stroke. In order to understand the impact of the stroke on the human body, we need to know something about the brain, because stroke mainly affects the brain. If you think about the brain, you can think about it as a ball divided into two parts, into two halves, the right hemisphere and the left hemisphere, the right part and the left part. The left side of the brain controls the right side of the human body and vice versa, which means that the right side of the brain controls the left side of the human body. Each one of these two hemispheres has certain vital functions for us to perform our daily living skills in life. For example, the right side of the body is controlled by the left hemisphere. Also, our reasoning abilities is controlled by the left hemisphere, as well as our language, whether it's spoken, written, or receptive, understanding the language, and the mathematical skills and the scientific calculations. All of these functions are controlled by the left hemisphere. So when we have stroke on the left side of the brain, we should expect deficits, impairments, difficulties. Like, for example, when the spoken language is affected, we might have something we call it non-fluent aphasia or expressive aphasia or Broca's aphasia. While if the understanding language areas are affected, we will have receptive aphasia or Wernicke's aphasia. If the area that connects them together is affected, we will have conduction aphasia. If the reading is affected, we will have something we call it alexia or dyslexia. While if the writing abilities are affected, we will have something we call it agraphia or dysgraphia, depending on the site of lesion and the severity of the lesion. While the right side of the brain is controlling the left side of the human body, and it's responsible for other functions like music, like art, like creativity, like insight, like abstract thought and following directions, spatial concepts. So these are the two main parts of the brain, the right hemisphere and the left hemisphere. We have also the cerebellum. The cerebellum is extremely important for functions like balance, like coordination. And we have the brainstem, and the brainstem is extremely important because it controls what we call vegetative functions of the human body, like breathing, like swallowing, and some other basic functions. So when the stroke attacks the human brain, depending on the site of lesion and the extent of the lesion, we should expect speech and language, swallowing, motor difficulties that may cause handicap and disabilities. Again, just to remind you that although the left side of the brain is responsible for the language, the right side of the brain is also related to the language by other means, like, for example, if it's affected our ability to judge the distance, for example, whether it's picking up or grabbing a pencil or more than that will be affected, judging our behavior and our judgments and our short-term memory. While the left side of the brain, as I said, responsible basically for the speech language problems, and it may affect our behavior and our ability to take decisions, as well as our memory and short-term memory in particular. The cerebellum, if it's affected, we should expect some kind of abnormal reflexes for the head and the upper parts of the body, like upper extremities, balance problems, dizziness, nausea, and vomiting, and these are related to the swallowing and swallowing impairments. Now, regarding the aphasia, which is a basic consequence of stroke, aphasia is a specific language disorder. It's acquired language disorder that affects the language in the four modalities. And when I say four modalities, I mean the verbal spoken language, the verbal receptive language, the reading, and the writing. All of these four modalities might be affected by aphasia. However, aphasia might be caused by other causes, like brain injury itself may cause aphasia. Primary progressive aphasia with Alzheimer's disease with the elderly people might cause aphasia. But here we are talking about aphasia that's mainly caused by stroke, whether it's ischemic or hemorrhagic. We have the expressive aphasia, and in this case, the patient will not be able to express himself verbally. This is why we call it non-fluent aphasia. The patient might have difficulty in finding certain words to express himself. We call it anomia. The patient might not be able to put the words together in order to form a sentence. We call it agraphia or agrammatism. While the fluent aphasia, the patient will be able to talk, but his receptive abilities are extremely affected, and in this case, we call it receptive aphasia. Now, there are connections between the Broca's area and the vernix area. If this area is affected, we will have conduction aphasia, which means that the patient will not be able to connect these two areas together, so he will not be able, for example, to repeat what he has been told to repeat. We have another two variations of aphasia. We call them transcortical motor aphasia and transcortical sensory aphasia. Transcortical motor aphasia is similar to Broca's aphasia. However, we have reduced speech output, but good auditory comprehension and good repetition. And this is the main differentiation factor between transcortical motor aphasia and expressive aphasia. While transcortical sensory aphasia is similar to vernix aphasia, and we will have fluent production with normal repetition and impaired comprehension. As I said also, if the written abilities are affected, we will have condition we call it agraphia, and if the reading abilities are affected, we have condition we call it alexia. So as you can see, the impact of the stroke on the human brain is devastating, and it may affect too many areas in the human brain. Another difference between the non-fluent expressive aphasia and the fluent receptive aphasia is the fact that the patient who has Broca's aphasia, expressive aphasia, will be aware of his or her difficulties. So when he or she finds themselves unable to express themselves verbally, they will be vulnerable to frustration, depression, and other kind of psychological consequences. While patients with fluent receptive aphasia, he will not be aware or she will not be aware of their difficulties. Now, there are certain factors that we are, as speech language pathologists and as a rehabilitation team, are very interested in. And when the patient comes to our clinic or when the patient is admitted into the acute care unit, we are interested in finding some factors that will help us to determine the prognosis of the case. It's well known that the incidence of this aphasia is about 180,000 cases in USA. About 1 million people have this condition, which means that about 1 in 250 people will have this condition. And aphasia, because of the stroke, it may reach until 40%, which means that 40% of our admitted patients in the ICU who have stroke will have these speech language and language problems. And this is why it's very important to determine the prognosis. So the prognosis, there is evidence to suggest that larger lesions will have poorer prognosis compared to the small lesions. Also, the affected areas, if it is the superior temporal gyrus in the brain, it means that there will be poorer prognosis compared with the other areas. The initial aphasia severity, when we assess the patient for the first time, if it's severe enough, we should predict low prognosis compared with mild or moderate abilities to express language. Also, the sooner the human brain can retain its ability to retain the cerebral blood flow and the metabolic rate, the better prognosis for the patient. Also for the gender, females cover better than males in oral expression, and females with global aphasia had better improvement compared with the other kind of aphasia. The age, the older we get, the poorer the prognosis compared with other kind of disorders. Handedness has nothing to do per se with the prognosis, but the pre-existing cognitive conditions and the education are thought to affect our ability to recover. So there is a weak evidence to suggest that age, gender predict recovery in patients with post-stroke aphasia, according to the clinical evidence practice. So again, the most important question for us as a rehabilitative team is to know what's the patient's potential for recovery and what's the best rehabilitation strategy for this or for a particular patient. And in order to do that, we get back to these factors that I just mentioned, and we try to link them with our assessment. Luckily, lately, we have some kind of algorithm by which we can determine the prognosis for stroke patients who have aphasia. So for example, when the patient has its 3D MRI image, we can construct it with a three-dimensional image of lesion and compare it to a certain database that has information about previous patients who have similar disorders, such as factors such as their age, their sex, their IQ, their handedness, their speech and language performance. And based on that, the algorithm, through interference engine in the system, can give me a score or an expected score. We call it longitudinal for all receptive and language skills that we can expect from this patient. So this is a good jump in judging the prognosis for our patients with stroke. So that's what I wanted to cover regarding language problems caused by stroke. We have also some speech problems caused by stroke, and here to differentiate between speech-based disorders and language disorders is extremely important, because not every stroke patient will have aphasia. Some of them, the motor areas will be affected, and in the conditions we call it dysarthria or apraxia of speech. Dysarthria, it means, when you see a patient with a slurred speech, the motor execution of the speech movements will be affected. And here you can see some deviation, paralysis, discoordination of the intraoral structures and the breathing system and the phonation system, compared with the stroke, with the aphasia per se, which is affected by which is central. I mean, the language areas in the brain are affected. Another condition which is usually associated with patients with expressive aphasia, we call it apraxia, and the human brain area that's responsible for programming the speech sounds will be affected, and this is why we call it apraxia, which means simply that the articulation will be off target. So when the patient wants to say something like pen, he may say like den. I mean, the word will be replaced, and the patient tries to correct him or herself, and his attempts will fail at the beginning. Now, regarding the assessment process, I'm very proud to say that I'm part of the team who developed the first Arabic authentic Gulf Arabic comprehensive aphasia test. This test is standardized on the eastern province of Saudi Arabia, as well as Bahrain and United Arab Emirates and Qatar. And it consists of 3 parts: the cognitive part and the language battery part, and the disability and questionnaire part, which evaluates the impact of the stroke and aphasia on the quality of life. Based on that assessment, we can determine our treatment. I will not go through every detailed treatment concept here, but I will focus on the general concepts that we follow when we put our treatment plan. We follow the WHO, the World Health Organization, International Classification of Disability Participation Activation part. We include the patient's impairment, activity, and participation into our goals, and we address them and take them seriously. Also, the patient and family-centered care is a main base based on which we can plan our treatment. Our treatment is designed for this particular patient, and we hope to increase the community support and integration of our stroke victims through life participation approaches to aphasia. If the patient is unable to express himself or herself verbally at the beginning, we might use computer-based treatment, either to enhance the language abilities or to use it as augmentative means of communication, which means that communication board or other means of communication that is not verbal. Among the treatment approaches that are very common in our field is the constraint-induced language therapy, which means that we force somehow the patient to use the language in order to express him or herself instead of using other modalities of communication. We have the melodic intonation therapy, which is based on the fact that the right side of the brain is responsible for music, and since the right side is not affected if the lesion is in the left hemisphere, we can use his or her abilities in the right side to compensate. We have multimodal treatment, especially for patients with global aphasia if they are severely affected. As I said, we have augmentative means of communication, and we promote the communication effectiveness by all means, like visual action therapy. We use it for patients with global aphasia. We emphasize the partner approach and supported communication intervention. We use some treatment that aim to improve the reading skills, like multiple oral reading, script training. If the problem is in the syntax, like patients with agrammatism, we focus on the syntax and the underlying forms of forming sentences. If it's in the semantic part, we focus on the word finding treatments, word retrieval cueing strategies, and a verb network strengthening treatment, and the semantic feature analysis. So all of these approaches are among our tools that we use to improve the function of our patients. Now, regarding the dysphagia, which is a swallowing problem caused by the stroke, depending again on the site of lesion and the extent of the lesion, the patients might have problems in the oral stage of swallowing, and we call it oral dysphagia. And when you put the bolus in your mouth and you mix it with your saliva and you start chewing it, this is the oral stage of swallowing. When the swallowing reflex hits, this is where the pharyngeal stage of swallowing starts, and we call it oral pharyngeal dysphagia or pharyngeal dysphagia if there is a delay in the swallowing reflex or the patient is unable to protect his or her airway while swallowing. And we have the upper esophageal dysphagia. Esophageal dysphagia is not under our scope of practice actually, but the upper esophageal sphincter is under our scope of practice. Our colleagues at GI deal with a kind of dysphagia that's esophageal based. But we deal with all these kind of dysphagia, and as I said, about more than 60% of our patients who are admitted to the ICU with stroke patients will have at the beginning swallowing problems, and they might be placed with a nasogastric tube, or some of them might be placed with a PEG tube. So it's very important to determine the prognosis of these cases. Among the prognostic factors, if the affected area is around the corona radiata, basal ganglia, internal capsule, the left hemisphere, and here I'm showing you these areas, we should expect low prognosis And what I mean by low prognosis, I mean that the patient will be fed by PICC tube after 6 months from the stroke onset. What we do as a speech language pathologist, we do bedside assessment, and based on which we can determine if the patient can take oral diet or not. If the bedside assessment is not enough, in our opinion, we might use some kind of instrumental assessment like modified barium swallowing study. It's an X-ray dynamic procedure which explains the oral, pharyngeal, oral pharyngeal, and upper esophageal phases of swallowing. As you can see, the food here is in black because we use contrast, and we can determine if the food goes in the wrong way into the airway instead of going completely to the pharynx and to the esophagus. And we have another procedure, and we are very proud to announce that it's here available in our clinic, which we call it fiber optic endoscopic evaluation of swallowing. And we are in the process of adding another feature to it, which evaluates the sensory aspect of the vocal cord adduction. And this is why it's called fiber optic endoscopic evaluation of sensory swallowing testing. These two procedures help us very much in determining the severity of dysphagia and to put our treatment plan. The treatment plan is usually can be divided into two parts, either compensatory or rehabilitative. Compensatory, which means that we can fix the problem at the spur of the moment. Like, for example, asking the patient to tilt his head to the right or to the left, depending on the site of the lesion, to put the chin down to decrease the entrance of the airway. We can modify the diet, for example, and use thickeners to make the liquid like thickener. And these are compensatory strategies. And we have long-term exercises that will help the patient to regain his or her ability to swallow. And these ranges from Shakir exercises to Mendelssohn maneuver exercises and some other exercises. The thing that we want to emphasize here is to talk about stroke as a medical emergency condition. So I'm sure that Dr. Shireen and Dr. Muayyad covered already the signs and symptoms of the stroke. It's extremely important as a caregiver or as a person to pay special attention to the signs and symptoms of the stroke, like sudden numbness or weakness of the face, like sudden confusion or trouble in speaking, like sudden trouble seeing things, walking, dizziness, loss of balance, and severe headache in the human body, and to call 911 or to go to the immediate nearest emergency department because the seconds will make a difference regarding the stroke patients. Another important factor that I want to emphasize before I end this English part is to stress the fact that the rehabilitation process is a long process. From the very beginning of admitting the patient in the inpatient rehabilitation facility in the ICU, till it goes to the subacute, till it goes to the rehabilitation center. It will be a journey, and it needs resilience, it needs motivation, it needs encouragement from the family, it needs, the stroke victims will need a lot of help, not only from the rehabilitation team that includes the physical therapy, occupational therapy, as well as us, the speech language pathologists, and the psychologists, and the clinical psychologists, and the nurses, and all other teams, including, of course, our great neurologists, but also the family. The family and the caregivers are extremely important in helping stroke victims to recover their abilities. Thank you very much for your listening. I finished my part regarding speech, language, and swallowing problems. Thank you.
Okay, hello everyone. Welcome from Johns Hopkins Ramco Healthcare. My name is Fawaz Abu Saoud. I'm a physical therapy specialist. I would like to talk to you today about stroke rehabilitation and physical therapy roles in stroke rehabilitation. We are taking this opportunity to talk in the World Stroke Day, which is October 29th, and hopefully the information that you will hear today will be beneficial to everyone. Before I go and talk about stroke rehabilitation and the role of physical therapy in stroke rehabilitation, I would like to talk about a very important concept in stroke rehabilitation, which is the majority of the next few slides will depend on this concept. And this is one of the things that we are facing in our clinic in a daily basis, that your case usually is different than the others. Here in this picture, as you can see, there are 10 different brains or 10 different MRI pictures of 10 different strokes. And you can see that the stroke in different locations in these patients. And I would like you just to think about that each patient, when he come and present to the hospital, he will present in a different picture than the other. And why this is important to us? Yes, because the end treatment to each patient will be different than the other. So from rehabilitation point of view, the concept or the program that will be designed to picture number 1 might be slightly different or completely different than picture number 3 or picture number 10. And why is that? Why this is an important thing to know? Because in stroke rehabilitation, we are working with a brain rewiring. It's a very complicated process. They call it, in medical terminology, neuroplasticity. We are trying our best to rewire the brain or reconnect the areas which is affected together, which is depends on the program that we are going to design to that specific patients based on that presentation. So this is a very important concept that we need to keep in our mind during stroke rehabilitation. Now, what is stroke rehabilitation? Post-stroke rehabilitations. We hear this terminology a lot. Simply, it is an integrated process that helps someone who has had a stroke relearn skills that are suddenly lost because of the brain damage. Equally important in rehabilitation is to protect the individual from developing a new stroke, for example, or a new problem such as pneumonia, urinary tract infection, injury due to falls, clot formations in large veins. So it is a multidisciplinary team where PT, physical therapy, occupational therapy, speech and language pathology, neurologist, nursing, all of them, it's a multidisciplinary team that they work together to design a program or a way of intervention to help the patients to regain their normal functions. In addition to that, they are working their best to prevent any further complications, such as the things that I mentioned. In a neurorehabilitation program, it must be customized to practice those skills that impair due to the stroke, such as weakness, lack of coordination, problem solving, problems with walking, loss of sensation, problems with hands and grabs, visual loss, a lot of problems. So it should be customized based on the clinical presentation during the first few hours or the first few days of admission to the hospitals. Remember one thing, which is very, very important. Research using advanced imaging technology shows that the functions previously located in the area damaged move to another area of the brain region, and practice, and I'd like to stress on practice, drives this rewiring of brain circuits, and this is what we call it neuroplasticity. And this is actually the things that we are working on it in rehabilitation or with a medical team, is to direct this process in a nice way and in a positive impact. I would like to differentiate between the role of physical therapy and stroke and transient ischemic attack. The patients might present to the hospital with a major stroke, where the symptoms last more than 24 hours. And here, the role of physical therapy, they will start with evaluating the case within the first 24 hours. Then they will start to provide the treatment, including putting the balls, sitting with the family, including everything. Then they will also incorporate in that, which is the education. And education is an essential part in rehabilitation program. Whereas in transient ischemic attack, the picture is a little bit different, where the symptoms of stroke last only less than 24 hours, where the physical therapy, they will go again, they will evaluate the case and provide the treatment if indicated, because the symptoms will be resolved in 24 hours. Then they will start to educate the patients about how to prevent stroke and how to use some safety devices or walking aids, for example, in case there is a need. So these two terms is really very important to understand. The role of physical therapy or the physical therapy stages, it goes under three different stages or important stages in the medical field. And as you can see here in the picture or in the diagram, that I put the patients and their families in the middle. And this is our high priority, is the patients and their families. The patients needs to understand what's going on. The family, they needs to be incorporated in the program, and they need to understand how to take care of this case, how to take care of this case in the acute stage, how to take care of this case in the subacute stage and post-acute stage too. And the subacute stage and the subacute stage is most of the time it will be in the hospital, within the hospital, and post-acute stage where the patients will be discharged either to another rehabilitation center or will be to the outpatients or discharged home. The acute stage, which is immediately the patients when he admitted to the hospital and the first few hours and first few days of the admission, the patients needs to be medically stable for the physical therapy to start. So in each of these phases or stages, the role of physical therapy is a little bit different. So once there is, for example, there is no movement, then the movements will start, so the program will start, and if the movements start to improve more, then the program will be restructured. The role of physical therapy varies, depends, as we say, depends on the acuity of the stage. Physical therapy starts when the patient is medically stable. Once the medical team, they give us the green light, then we need to start. In Johns Hopkins Aramco Healthcare, physical therapy is part of the stroke pathway, where the patients will be assessed within the first 24 hours of admission. And we will identify whether the patient is medically stable or not by our also communication with the physicians. Interventions are designed based on the clinical outcomes or presentation. Of course, patient is able to walk, patient is able, he's bedridden, all of these, it's really matter. Early mobilization is an essential step in acute stage, which depends on the physical assessment and the patient's condition. Most of the cases that we are facing sometimes is that the family or the patients are reluctant to move the patients out or to let the patient move based that this patient is tired, he is sick, and he cannot move, he has stroke. No, once the patient's actually medically stable, evidence-based evidence or studies, they showed that early mobilization is really important to keep this neural structures alive or help to reconnect these neural structures. Proper positioning in acute stage can prevent further movement complication. Of course, we are going also to teach the family and the patients how to reposition the arm, how to be on your right side or left side, how to stand, how to sit in a chair. And my colleague from occupational therapy will elaborate more about this part. Patients and family education from day one is really essential. We need everybody to be in the same picture to understand what's going on. Now, let's go in deep and understand more what's our role as physical therapists in stroke rehabilitation. Usually in physical therapy, we hear like in JAHA, we provide combined sessions with our colleagues from occupational therapy and speech and language pathology to be as a team working on that patient in that session to provide the optimal results from the session. And our part actually starts from the background, sitting with the patients, reading in the chart, and understanding what's going on. Where is the stroke actually? What's the previous functional level? What's the previous medical complications or problems that the patients have? And the information that we are going to collect in this step it's actually forming the base of our understanding or decision to that patient. So our role will start from collecting those informations at the beginning, followed by assessment. We'll go to the patients. Actually, we'll start our physical assessment. And physical assessment, we are do the assessment for the patient's readiness to start the physical therapy or the program, cognition, behavior, sensory function, coordination, mobility, community participation, the ability of that patient to do advanced functional activities, and so on. When we get some information, also all the information that we got from our assessment part, we will add it to the background, that the information that we collected from the background. And this actually will make our decision or background about this case more stronger. This will help us to put the goals and how to educate the patients. And when we put the goals, what we are going to do, either as short-term goals or long-term goals, and we are going to discuss this with the patients and their families. And they need to understand the path. They need to understand they need to be incorporated to that. Family are really, really important. Home environment is really important. We are working together, the clinic and the home, merged together to provide a good understanding or better motor control in the future. We will start our treatment based on the goals that we are setting. And the treatment includes joints limitation, improving the joint limitation problems, working in the motor impairments, sensory impairments, balance, gait abnormalities, functional activities retraining, assist with return to work if indicated, coping strategies, and cognitive impairments and neuroprotections, how to protect your central nervous system after stroke. So we will continue with the treatment, whether the treatment will last for 1 week or if it's for a few months or more than that, then whether the patient needs to do intensive rehabilitation in a different setting, all of this will be under treatment, and the treatment will not be the final step. We will go and continue and do reassessments and planning. We will reassess the function regularly, in a monthly basis, on a weekly basis, based on the stage or in the case. Provide continuous feedback to the patients and their families, and also we will set a new plan if it's indicated. There are essential aspects or essential aspects that we need to understand when we go and work with the stroke cases, and everybody needs to know about this, that these things or those things, actually sometimes it will delay the recovery process. It will delay the program. We'll say that the program will take for 2 months, 6 weeks, and sometimes the program will be delayed based on something unexpected, or we call it stroke clinical consequences. One of these essential aspects that we identify usually in the clinic is the patient's readiness. Sometimes most of the cases, most of the patients, and they actually tend to push the patients to start as early as possible in intensive rehabilitation program. And there is difference between regular physical therapy intervention and there is intensive rehabilitation program. And sometimes the intensive rehabilitation program, if we started too early, it will be harmful to that case. So your treatment team will guide you when to start the rehabilitation, the intensive rehabilitation program. One of these factors also, the right hemiparesis versus left hemiparesis. This patient, his right side is affected, is different than the patient who has left side affected. If the right side affected, there are some issues that will be present in that case with stroke case that will not be present when the patient has left hemiparesis. For example, hemineglect, for example, Pusher syndrome, a lot of things, communication problems, emotional things. So these sometimes it will be triggered at a certain stage that it will also delay in the rehabilitation process. Fatigue. Fatigue is something common during the rehabilitation program, and fatigue, it varies between this case to that case. And actually, we are working together with the multidisciplinary team to overcome this fatigue to allow the patients to be able to participate more active in the program. Cardiovascular complications, patients who has cardiac problems, for example, it might also delay when there is an active cardiac problem going on during the program. Mood complication, this is something common also. Patients today is in a good mood, tomorrow he will not be okay, he's not in a good mood. So this will also affect his ability to participate within the program. Different things than that, which is, as we discussed about the intensive rehabilitation, whether it is a good time to start the intensive rehabilitation or not. Sometimes, and I put it like this, because sometimes the people tend to send the patients early to intensive rehabilitation, which sometimes when the patient will not get that benefit. Functional recovery versus neurological recovery. Yes, you will see that the patients start to feel the sensation. The patients will start to move the arm or move the leg, but it doesn't mean that the patient is able to drink water or to walk. And sometimes, yes, there will be a delay in the functional recovery and sometimes needs more guidance by the team to improve this function. Family support, and then I put it like this because sometimes excessive family support will delay the program because the patients will be reluctant and will depend on if there is support, he will be more motivated. If there is no support, then the patients will be lazy. Home environment, the patient has safe environment, he has supportive environment at home, then also this will help him to go smooth during the program. The severity of the brain damage, as my colleagues in the previous presentations, they mentioned it. If the stroke is a large stroke in more different parts of the brain, it's different than there is small stroke and one part in the brain. Age also, it matters, and sometimes it's affecting also in the quality or in the recovery process. Here I would like to show something which is, we face it a lot in our clinic or in the daily practice, that we have a concept, as I will put myself as a patient sometimes, that I have a concept that I have to go to the clinic, I have to see a physical therapist, I have to stay in this high advanced quality center, but I'm ignoring the home part, which is really, really important. Because in physical therapy or rehabilitation program, we are actually trying to merge between the home environment and the clinic environment. The home, there is some aspects or something provided at home will not be provided or available in the clinic. And at home, the patients will be, it will enhance the functional mobility. I'm in my environment, I used to that, I know where's the bathroom, I know how to move, this is my bed, so it will enhance the functional mobility of that patient. And also follow the home program. The patients will be more free to follow the program that he has. The rehabilitation team, they will provide him with that program that he will work or she will work on it at home. And also the family, they will be there. It's not only the father, it's not only the son, the whole family will be there that will push and motivate the patient to work on that program. Then the patients need to come to the clinic in case if it's needed, because in the clinic they need to, sometimes in certain cases they need to use specialized intervention. They need to do special equipments, to use special equipments with that patient. And it's easier for the therapist or for the team, medical team, to communicate with the other stakeholders. I can talk to the physician, I can talk to the dietitian. It's much easier. But also, for example, here at Johns Hopkins, the patient has the ability to communicate with his physician through the MyChart application. So we are trying to enhance this, also improve communication at home, so the patient has no difficulties to communicate with his medical team. So home environment and clinic is really essential to work together. We face this question, how to take care of stroke patients at home, or stroke patients at home. And I summarize it in these 8 steps. The first one is encourage. Encourage your daily mobility and exercises. Ask your patients to move. Ask the patients to move from bed, to go and have breakfast at that chair. Ask your patients to do the exercises that is prescribed to him. in a daily basis. There is a routine that they need to follow. So encouragement is really important. Routine, try to create and establish daily routine that your breakfast will be at this time, medications, you need to do exercises, your sleep will be at this time, we have to do this and that. Instead of having breakfast today at 10 o'clock, tomorrow at 7 o'clock, this also will interrupt all the recovery in the central nervous system. Overcare. Do not provide overcare. Do not say that he's tired, I need to help him. Yes, help is really important, but not do overcare. Do not provide overcare. The patient need to explore the environment. The patient needs to understand his or her limitations. And with the help of the treatment team, they will help him to overcome those limitations. Socializations. Do not isolate the patient. Encourage social interaction with and communication. This will improve his communication, his ability to tell. Most of the patients, they say, oh, we don't want to go there because I don't know how to pronounce things, how to say things. No, we actually encourage the patients to go and communicate because this will improve it. And new changes, either it's a positive changes or negative changes. Keep an eye on your patients. Watch for side effects or status changes and report that to the medical team. Ensure that there is a safe environment and safe, effective use of the assistive devices. When the patients use the walker or a cane, ensure that it is safe, and if there is any issue, you can report it to your physical therapist. Medications. Do not change any medication or change in the dose without consulting your physicians. For the diet, we are facing a lot of questions. What type of food do I need to take because I have stroke? And I prefer to consult the right person, which is the dietitian, consult them for the effective diet or the best diet in your case. Now, how can I prevent? I am a normal person, for example, or a stroke person. How you can prevent another stroke, for example? There are different, when they summarize it, the National Institute of Health, they summarize it in around 6 items or 6 points. The first one is stop smoking. The second one is control high blood pressure, manage your diabetes or control your diabetes, check for any heart diseases, lower your cholesterol level, and something which is really important related to physical therapy, exercise regularly and maintain weight. Sorry for that. I'm sorry for that technical issue. I would like to take a few minutes now just to talk about common questions that we are facing in our practice. And one of the questions is why the patient is not improving. And the patient there's slow improvement or there is no improvement. There are a lot of factors. Sometimes it could be the readiness of the patients, or when we started the intervention or the rehabilitation program. Sometimes it's the age, it's a medical problem, previous functional level, previous patients has sedentary lifestyle, level of education. Now there are researchers, they are studying the genetic factors that are affecting that. So there are a lot of factors. Physical therapists, they cannot answer that exactly this is the factors that are affecting the slow improvement or there is no improvement. Should I buy a specific equipment to be able to use or exercise at home? And actually, I would like to say here that it's optional for the patient, but if there is a specific need for certain things, of course, your physical therapist will guide you. Can I go for a traditional medicine? Actually, what we are actually recommending this in this question is to go and discuss this with your physician. If you have an intention to go or you have a plan to change any kind or to try any kind of treatment. Does massage help the patients? Evidence say that massage, it helps to relieve the tension because the patients, they will have continuous fatigue. So the massage, it will help to relieve the tension or decrease the tension. but we don't recommend this on a daily basis, and we don't consider it as an essential part in the rehabilitation program. How much physiotherapy will I be able to have? Actually, this will depend on the case and the presentation and the need, and the physical therapist will decide about that, and they will discuss this with the patients. Another question is, can you explain whether I might benefit from electrical stimulation? Electrical stimulation is beneficial. It's for certain complex problems related to the movement or sensation, and sometimes we use it. But actually, your physical therapist will tell you exactly the proper time to use the electrical stimulation and whether it is needed or indicated or not. Other question, how can you help me to walk again as quickly as possible? There is nothing we call it quickly. We do our best to let the patients to go um, more active as much or functional as much as we can. But there are some things for any task, movement task. There are a preparation process that we need to work on it step by step to form a certain task or to let the patient to do certain tasks. So sometimes walking is not the priority at the beginning. It will come at a certain stage. How can you what happens if I get very tired or have other problems during my therapy? Actually, if you notice any changes, you need to report that to your physician or the treatment team. They either change the program, modify the program, reduce the intensity. And as we say, that fatigue is something common in stroke rehabilitation or when you start intensive program. Why I did not recover like my friends who have a stroke and able to do this and that. Actually, this will bring us to the first slide about the concept that don't compare this case with another case, because the stroke here is different than the stroke there, age is different, manifestation is different, this person is different than that person. So in neurological cases, usually we don't compare. Yes, there are something common, but even the program sometimes it's different between one patient to another. Finally, in conclusion, I would like to say that stroke rehabilitation is essential if indicated at the right time. The stroke rehab program will be customized based on the patient's needs and the abilities, based on the patient's presentation at that stage. Physical therapy rules vary based on the acute stage. It's different in the acute stage than the subacute stage than the post-acute stage. Stroke medical consequences are different factors that might delay and or slow the progress and therefore the expectations of the patients. Home program is essential and considered part of the physical therapy program designed by your therapist. So as we said, home and clinic, they work together. Daily exercises is an important factor in maintaining a healthy lifestyle prior and post-stroke, and regular exercises and ideal weight are considered two main recommendations of the stroke prevention program. Finally, I wish you a safe life and thank you very much for listening.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome in the Stroke World Stroke Day. My name is Abdullah Al Muzayin, occupational therapy. I will cover or highlight the role of the occupational therapy with the stroke patient. Uh, so the stroke management team works. The occupational therapy work with multidisciplinary team to treat the stroke patient. The team including physician, clinical dietitian, physical therapist, nursing, and healthcare. What's the occupational therapy or occupational? Who is occupational therapist? The occupational therapy definition, according to the World Federation of Occupational Therapists, occupational therapy is a client-centered health professional concerned with promoting health and well-being through the occupation. The primary goal of the occupational therapist or occupational therapy is to enable people to participate in the activity of their everyday life. So the occupational therapy initial assessment with the stroke patient include multi or different areas. So the area of the activity of daily living, the occupational therapy will assist the stroke patient with these areas, activity of daily living, for example, the self-care, functional mobility, functional transfer, functional communication, and it will assist the environment. Also, the occupational therapy will assist the sensory motor, which including upper extremity, lower extremity, sensation, perception, it will assist the range of motion, and it will assist the muscle tone. Also, occupational therapy will assist the cognitive function of the patients, to assist long-term memory, short-term memory, for example, executive functions, orientation, attention, and the ability to follow the instruction. Occupational therapy also will assist the psychosocial areas and the play areas, the pleasure area, the social participation, and equipment need assessment or assistive devices. The occupational therapy intervention with the stroke patient in acute stage or in subacute stage depend on the patient condition and the complication, of course. The area for the intervention is different, or the modalities is different. It depends on the severity of the patient condition, which include positioning, edema management, splinting application or splinting need. Also, it will the intervention would encourage the early mobility or the early mobility program of the stroke patient, EDL retraining, family caregiver, and the health worker educations. So I will talk about the positioning of the stroke patient. It's really important to know the appropriate position for the stroke patient in different position. For example, the dark here in the pictures, if you saw the dark part, it's the hemiplegic or the weak part of the body. We should support it slight elevated, put it visible, and in the front to prevent the complications and to prevent to harm for if the patient of the stroke patient. And we should consider different position for different posture and different position, which include, for example, in sitting, if we put the table, that's much better, and we will put the arm a little bit elevated, supported, visible. Also, we apply this role in the supine position or in the sideline position. Also, occupational therapy intervention with the edema management. We support or we encourage the nurse or the patient itself, or with occupational therapy, like encourage the support elevating of the arm. Occupational therapy intervention also for the passive range of motions or a light retrograde massage, or occupational therapy will provide a splint. May be used not all the patient, but with some patient, to support the normal alignment of the hand and the wrist, to avoid the nerve interruption, which may be contribute to the swelling. Also, the education part and advice for the patient, family, caregiver, and other staff to manage the effect. Important of the splint applications. This is the role of the occupational therapy to play with the stroke patients. They are wide, the range of the material of the splint. And we should consider if that like any active movement. So if there is active movement, we will not apply any splint. We encourage the active movement of the limbs, and we avoid to apply any splint in this stage. So the many different aims of the splint or reason, and I will explain a few of them. So the aims of the splint, maybe it could be for the reducing the spasticity, or reduce the pain, or reduce the edema, or to maintain the joint position and alignment. Also, we apply some type of the splint for functional reason or for exercise to encourage the active resistive exercise. Also, occupational therapy will interfere or will assist the area for the equipment need and need for the assisted device. For example, we assist for the need of the wheelchair to develop the community mobility, or to transfer a patient from one area to another area. Also, it will assist the need of the commode for the toileting, for the showering, or also it will assist the need of the assistive devices, spoon or fork for the main preparation or for the eating. So at the end, the role of the occupational therapy with the stroke patient to maximize the patient level of independence within the activity of daily life. Thank you very much for your listening, and hope all like in good health and wellness. Thank you.